Well, good morning, everyone. We made it to day 3, which is exciting. I get the pleasure of hanging out with a bunch of EM docs, which is my dream, so that's awesome. Welcome to Critical Mass, Resuscitating Urgent Care in a Post-Pandemic World. I'm going to introduce these guests with me. We've got Michael Watts, CEO of Bloom Health. We've got Jared Troutman, who most importantly is a fellow Texan. He is the National Medical Director of Global Medical Response. We have Hannah Schroeder, Senior Physician at ICHON Institute for Rescue Management and Public Safety. And then we've got Daniel Lakoff, who is the Director of Emergency Medicine at New York Presbyterian Weill Cornell Medicine. As we begin our discussion, if you have any questions, please do send them through the app and I'll be able to see them on the iPad. So obviously we all know that overcrowding in emergency departments is a big issue. And to kind of level set, going back to May of 2023, the Society of Emergency Medicine in Europe surveyed their physicians, and 90% said that at one point or another, they felt like there were unsafe conditions to take care of their patients. And so I like that we have a geographic diversity. We've got yourself from the United Kingdom, we've got 2 Americans, Hannah, you practice in Germany. So I'd love to hear from each of you how in your environments, what you see as the most worrisome problem when it comes to overcrowding in emergency departments.
Thank you, always. So thanks everyone for being here as well. But I think the biggest thing for me is the fact that it's very difficult to do anything about it if we think about infrastructure first. You know, to build more beds into an ER is an extremely difficult thing to do. So we have to think outside of the box when it comes to thinking about new ways to support moving patients through an ER as fast as possible, because ultimately that's what we're there to do. As emergency medics, our decision is to decide whether a patient needs to stay in hospital or they're safe to go home. And the faster we can do that, the more efficiently we can do that without compromising safety, the better. So that's where I like to think about the innovative ways in which we can change the way that we manage emergency rooms. For example, waiting rooms. The waiting room of an A&E department is actually one of the most unsafe places. If you think about it, you've got up to 60 patients of varying illness that we don't know about, and perhaps 1 or 2 triage nurses looking after them. So if the care quality commissioners, the people that manage safety in the UK, saw that as a ward, it'd be shut down straight away. Yet we have these patients there in that waiting room. So we need to start to treat the A&E department in the same way that we treat the rest of the hospital, and think about how we can introduce things like digital technology, digital health, to actually move patients through these places more effectively and more safely.
Hi everyone, good to see everyone here. You know, when I really think about emergency medicine and EMS, I really think that we see public safety has been largely of what we do, really taking care of those really critical, highly acute patients. But we're seeing more and more public health fall into our lap. And patients that they just don't know what to do or where to go, they have a problem, it's an emergency to them. And so they turn to the emergency care system in your country and look at us to help solve what the problem is. And it's up to us to offer some sort of solution, and those can be rather varied.
Good morning, everybody. It's great to be here with you this morning. In my point of view, our emergency care system in Germany has become like the front door to access the healthcare system. So we are seeing an increase of EMS missions over the last years. We see patients and elderly population overwhelmed how to access the healthcare system. And in my everyday business in our research institute, we're working on innovative solutions, how to perhaps divert patient flows differently than we do right now, because we will not handle any longer every patient ending up in the emergency department. So I'm very happy to discuss on and learn about solutions for that challenge.
Good morning, everybody. Thank you for joining and sticking out to the final day. I couldn't agree more with my colleagues on stage. I think internationally, from the conversations that we've had here, the emergency department sits in the same type of position across the entire globe. We are considered the safety net, but my belief is that that's a misnomer. We're more of like the last bastion of help, the final fail-safe for most of society. One of the huge gaps we have is that we need to kind of expand that thought and truly build a safety net for our population. We need a collection of clinics, urgent care centers that will be able to help with potentially a deluge of patients that are going to be coming in and identifying disease through some of these incredible technologies that we've learned about this past week. So I'll bring it back to the fact that we just need to reclaim the name safety net and build something bigger out of that as opposed to one solitary area, the emergency department.
So, Daniel, I want to stay with you. We talk about this issue a lot in the post-pandemic world, but we've been talking about emergency department overcrowding for decades, right? How has the problem changed, or has it changed post-pandemic, and in what way?
I think what we're seeing now is immediately post-pandemic, we had a big decrease in arrivals to the emergency department, but there's been a gradual increase in arrivals every year, and the acuity has been increasing, and it's been quite impressive. On top of that, we've also heard here on this very stage some of our workforce issues in that the doctors, the APPs, the nurses are all burning out. We have a shrinking workforce, some millennial shifts in terms of the concept of how they want to work, and we're suffering in the emergency department. So we need some assistance there.
Michael or Hannah, in terms of the European picture, pre-pandemic to post-pandemic, any thoughts on that?
Yeah.
Okay. So I can say we see the same as Daniel already said. So the population was kind of afraid entering the emergency departments, even more through the COVID pandemic. Therefore, we also have seen delayed begin of therapy for really critical diagnosis as stroke or myocardial infarction. And that's something that we have to educate. Yeah? So there are certain diseases and illnesses that have to be attended on point. And there's a great sector of low acuity issues we have to educate on that can be handled by other by other things than emergency department. And I think we haven't figured out yet how to point that out for the public and how to understand when I actually have to go to the emergency department and when I can attend a different service.
I think in the UK, obviously, we have a free, at the point of access, healthcare service, which has meant for a long time the A&E department has often been a place where people can be sent quite easily, and that's created a lot of pressures all the time. Even thinking about social care, often frail patients, older patients will end up in A&E because they don't know what else to do with them. So we have seen an increase in that post-pandemic, but what we've also seen is the ability to manage patients more effectively in the community, and actually through things like digital health, telemedicine, remote patient monitoring, actually try to prevent that person landing up in A&E and actually think about other ways to keep them in their place of residence. Because if we can treat them in their place of residence, then we start to reduce down that burden. So I think the pandemic has enabled us to think about alternative ways of managing patients before they get into A&E. But of course, the bigger challenge that we have is that there are also more ways for patients to now access emergency services. And in a society where it's a free service, obviously it's about how do we manage that more effectively and prevent or create more admission avoidance, which is now a big target for the UK, is how do we avoid admissions through things like urgent treatment centres and sort of interventions through 111 sort of elective services.
Yeah, so I'm glad you brought up urgent treatment centers because that is a part of the solution. Mm-hmm. And Daniel and I were even having this conversation the other day. In Texas, there are urgent cares all over the place, mm-hmm. every other block. In New York City, there aren't that many. Mm-hmm. And so question for whoever wants to kick us off, what is the role of urgent care? Where is it falling short? And where can it go to where it actually is utilized as an alternate pathway for care and keeping patients out of the ER if they don't have to be there?
So I think it becomes a patient education standpoint partly, but patients just whenever they don't know where to turn, we've just been told to call 112 or call 911 or just go to the emergency department. So changing that dichotomy is very difficult. I would almost encourage more patients to call 911 or 112 and then let the patient talk to us, and then we have a safe way to triage the patient. Maybe sometimes it is an emergency department, but it should be okay and acceptable to that patient for us to say, actually, an urgent care would fit you greatly, or maybe a telehealth consultation, or have a provider, a nurse or paramedic that could just talk through the problem and say, I know your blood pressure is a little elevated, you have no other symptoms, it's okay to wait and see your doctor after the weekend. So I think we have to change that dichotomy. So many times right now there's an expectation when patients call that number that we're going to send an ambulance and you're going to go to an ER. But we've had data that actually shows if you don't do that, patients are actually very satisfied with it. They just have a problem. They want a solution that's reasonable to them and keeps them safe.
Not only that as well, but actually the waiting times in A&E departments are so great now that actually these provide good alternatives where people can get an answer quite quickly. We have 4-hour waiting times for a paramedic to arrive. We have over 4-hour wait times in the waiting rooms. So someone can now spend a day in A&E and that be the total normal thing for non-acute or non-emergency issues. And I guess that's my point, is that there are non-emergency issues in an emergency department. So therefore, I think 111, 112 has been a really revolutionary way of being able to senior stream triage the way that we manage these patients and try to keep them in other pathways where they get more effective treatment for their pathology.
I can.
I think in Germany we're way some steps behind on that, because what Jared said, that the opportunity to triage the patient into a different care sector starts in the dispatch center, and we still are facing the challenge that our care services are not linked with each other. So if you in Germany call 112, and it depends on where you live, in the end it's only the one button to hit to send an ambulance. So we're still facing the challenges that the on-call services are not really connected with the emergency call services, and that's so some steps we still have to do to face that. Even if by legislation we have 8 minutes for an ambulance to arrive, and well, in my city we do that around 60-70%, that 8 minutes. Of course, it depends if it's rural or urban areas. But so the last 10 years, what we did is more ambulances, more ambulances, more ambulances. And we will not be able to do that in the future anymore.
I'll just piggyback a little bit on what you said. In terms of connectivity, we do in New York have quite a few urgent care centers. They're all for profit, and ultimately they sit amongst the population, and the population has been using them. It's the way patients want to reach care at their convenience, in a location of their convenience, and they've been using it with great success. The problem that I've seen is that these turn into single episodes of care, and it's a lost opportunity to really connect them to a place to manage their chronic symptoms, their chronic conditions, and those episodes of care are just completely lost. We don't have the digital connectivity to their electronic medical records. So frankly, they don't even call us if they send a patient to the emergency department, and that's a lot of lost information, a lot of time that the patient has spent explaining their information, their conditions to a doctor or a PA or nurse at these clinics, and it's completely lost. So we need to do better to strengthen this connection between what's out in the community with what's in the hospital.
Do you think that comes from large health systems and getting support from them, or is it a government solution, or both? Or
I think the government may have to step in, because ultimately some of these urgent care centers are just extracting financial value. They're very good at collecting some insurance money, but they're not giving back to the system. I think there's different models in Texas that you've explained where they're connected to the hospital system and they belong to the hospital system, but not in New York. It's rare to find an urgent care that belongs to a hospital system.
Yeah. Jared and Hannah, kind of delving deeper on the pre-hospital EMS side of things. I like to, we all see these patients, they may not have insurance, they may not have transportation, they ran out of their insulin a few days ago, and the easiest thing is calling 911, getting that transport to the hospital, getting a medication refill, getting it filled at that pharmacy, and for them it's a one-size-fits-all solution that they've relied on for years. we have to get buy-in from them to trust the system to say, hey, we're going to take you to this clinic instead. How do we get that buy-in? How do we encourage them to be trusting of us? Because a lot of times we have failed those populations.
Yeah, so we have a 911 nurse navigation program, about 30 different cities across the United States. And before we started that, one of the naysayers was, well, patients will never adopt this. If they call 911, if you show up with any less than an ambulance and take them to an ER, they're going to be upset. But every patient we navigate, does get a call back, and we say, what did you think of the service? And it's a 4.8, 4.9 out of 5. So I think there's a reality, and with many things, we're afraid to take that step because we don't think there's going to be a particular outcome. But I think it comes back to that. The reality is patients just want a solution to their problem. We think they want something, but as long as we offer them something, we shouldn't say you shouldn't have called 911 for this. Why didn't you do something else? We never diminish that that's an emergency to them. It is an emergency to them, and we solve their problem. We become a GPS navigation for their health.
Yeah.
I totally agree. So we also think that the patient actually defines the emergency. So he wouldn't call if he wouldn't feel there is something where I need help for. And it's up to us and the system to see and to analyze what kind of patient perhaps is a frequent user because of a social problem, because of homelessness, because of chronic disease that's not really good attended by his GP, whatever. And in lots of cases, I think the answer is not the high-equipped emergency system, but the social worker that connects to the people, and about connection and finding solutions, diverting them into the right kind of care. Perhaps it's just about having a translation for some health insurance format that's not in his language. Yeah.
Can I just add another case study to that? Because I agree with the social work that Hannah identified, but also want to call out some more good practice and a good case study, which is a friend who's actually sat in the audience who runs a general practice, primary care practice. And he has a dedicated physician who sits there taking calls, because actually in primary care we also don't have enough slots for the patient, so therefore their next thing is to go to an urgent care centre or an A&E department. So the NHS doesn't pay him to do this, but by having a dedicated doctor to be able to take the calls of patients who otherwise can't get a designated appointment slot, he's then able to senior stream those that actually do need to come into the practice, those that might need to go to the A&E. So A&E starts in the community, right? And I think we need to really empower the primary care physicians, the social workers and the community nurses, the care and residential homes. We need to stop or support the care and residential homes so that they don't feel that the only way they can support that patient is by sending them to the A&E department, because we know that when these patients end up in the A&E department, they often stay there in the hospital for weeks, because it's really difficult to socially discharge them, or we end up finding something else which they then need additional care for. So care starts in the community, and we should be empowering primary care physicians to support patients and prevent them landing in the A&E department.
Yeah, and they're getting them admitted leads to other hospital-acquired infections and falls and things like that. That is bad for the patient, bad for payer, bad for everyone.
Exactly.
Obviously, every talk we've been to, we've talked about technology, AI, telemedicine, all the things. So we can't ignore it here. You obviously, as CEO of Bloom Health, work on a lot of software solutions to these issues. Are there things that stand out to you that are addressing this particular issue of navigating patients to proper care pathways that are technology-based, that are on your radar?
Yeah, absolutely. It starts with data, right? I mean, that will be on everyone's bingo cards, but we don't actually have good enough data about true admission avoidance. We have good enough information around what a typical patient looks like and the typical patients that will probably end up in hospital based on their vital signs, based on their presenting complaint. So we do know who's going to go to hospital, and therefore we should also know who might be heading into an A&E department, but therefore we diverted them, and that's a true admission avoidance. So when I ask these urgent treatment centres, some of these community care providers, they don't actually know their admission avoidance rates. So we need to understand better how well we're doing at this stuff. Once we know that, we can then start to apply some return on investment into things like digital solutions, telemedicine, being able to support the paramedics and be able to give them tools like digital apps, patient self-education, because like we've said, a patient just wants an answer, and actually it's quite difficult often for a paramedic to give them a direct answer. They might be able to give them some medicines, they might be able to give them a blood test, but actually being able to give them advice and guidance through e-leaflets and things like that. There's little things we can do to really kind of support patients through digital. And then once they land in the A&E department, it's more about being able to continuously monitor their vital signs, being able to increase flow through the A&E departments, but also keep them safe through things like alerting systems, smart bell systems, where we can actually give patients, so Bloom are actually giving patients in the waiting rooms emergency bells through an iPad, where they can actually tap, I'm in pain, I feel nauseous, there's been a fall, there's a threatening patient, so that we can actually create that situational awareness in a rather unsafe place where there isn't that communication currently, other than a hardwired bell that you kind of pull and everyone rushes and leaves their also vulnerable patients.
So everyone agrees we have to keep safety as paramount. So it's how do we get to that most safe spot? And we also know once a patient has accessed 911 or 112, the best time to divert them from an ER, A&E, is earlier in that chain, the better, so from our dispatch center. So that's where it really does come back to data and having all that data, good data, leveraging things like AI, to sort through that data to know when these dots connect, it's safe to send that patient to an urgent care or to a telehealth type situation, or for the nurse to say it's going to be okay. I think that becomes incredibly important. And then also some of the fascinating tech stuff we see, like vital signs. You know, we have vital signs if I'm next to you, but now to be able to do that through a video, and each year we see higher reliability that I can count on that heart rate. Vitals are vital, and if there's more information I can get through telephonics or through telehealth, the more I can be assured of safety.
In my region, in 2014, we implemented a telemedical EMS system with a tele-emergency physician sitting in a remote place and attending calls from paramedics in the streets in their missions and supporting them with any issue they bring up. And over the years, now we're looking back on 10 years of duty, we had over 40,000 teleconsultations at this tele-EMS center. And with over the time, we're now at 30% where the telephysician agrees then with the paramedic that the patient can stay at home. So in this case, it gives not also legal backup for the paramedic, but also confidence for the patient that it's really fine, and somebody checked on vital signs, 12 leads ECG, checked on the background and took into account the patient history, and it's fine to go to your GP tomorrow, on Monday, whenever. That do it with a good feeling, because we have to also take into account how people do their work, and if it's they're satisfied and confident then with the decisions we take. It's not only to spare resources, but to spare it with a respectful way for staff and patients. And I think that's one solution that's possible. Of course, we know that in Germany it's a very physician-centered system. So we have a lot of missions that are attended by physicians on the scene as well. And another effect of this telemedical system is, of course, that we could immensely reduce our physician quota in the EMS. And that's attractive for insurances as well.
Yeah. I'm curious, Jared, you brought up the legal aspect of thing. In the US, what does the legal liability of navigating someone away from an ER look like? Have you seen trends where it's more risky or not really? Or?
So I'm going to knock on wood, because as far as I know, there hasn't been any litigious case on this, because it's just not as common practice. But at some point, it'll be questioned, and there will be a case, because we know that certain states are very sue-happy. So we'll see where it goes then. But I think that's where it really comes back to having that data, leveraging AI, and really being able to be keen on safety, so that when that case does come up, we can go back and look at, and then hopefully peers can look at and say, that was very safe, there was nothing done wrong, it was all done very appropriate.
Yeah. Daniel, we were kind of talking about frequent visitors to the emergency department. We're all familiar with that. And there were some technological solutions that I think that your system kind of works on. I think that would be useful to bring up and share. I was really intrigued. I hadn't heard of that type of system in Houston.
Yeah, so absolutely. So we're fortunate in that we have a very connected informatics system. Our electronic medical records, not only within my system of 13 hospitals, is connected, but we have also the access to the rest of the region's hospitals' electronic medical records. So we can easily do a quick search of the patient's prior visits, look at their notes, look at their labs, and be able to collect all that information into a pool of information, and then we can create care plans for patients that we can put into patients' charts. And that's easily visible within our system, and then also to other systems. So we can kind of all strategize together on what's the best way to care for this patient. The fact that they're coming to the emergency department is ultimately a failure of the system in that we're not doing something for them. We're not meeting their needs in a certain way. So each and every time they come in again, we can extract a little bit more information, put it into the chart, and ultimately create a better clinical picture for the patient, and ultimately send them in the right direction. Do they need a primary care? Do they need a specialist in hematology and oncology? Do they need their social services really addressed to help them feel comfortable at home? Whatever it is, we can start putting a better clinical picture together, which is hopefully sends them on their way to health.
And so far we've discussed a lot of solutions that even if all of them were implemented perfectly, we would probably still have a lot of people coming to the ERs. Now, I guess the elephant in the room when I look at it is that we have an aging population globally, whichever country you look at, and people are going to be sicker over the course of our lifetime. So even if we implement all of these things, are they going to be enough to kind of cope with our aging, more sick population over the decades to come?
It's a challenge, right? It's the typical bathtub analogy of the tap is on and it's flowing faster. So we need to think about ways where we either slow down the speed of the tap so we keep more patients in the community, we reduce down the amount of time that patients spend in hospital to improve patient flow, and then the third thing perhaps that we haven't really touched on because it's not really a part of an ER doctor system, although it does matter, is effective discharge and prevention of failed discharge, because I think failed discharge is as important as first presentation. If someone goes home and then they're back in 2 weeks later because actually that was a failed discharge, then you are effectively feeding into a system that is already at capacity, and that's where the bathtub overflows. So we do need to look at the whole system when we're thinking about transforming the A&E department. And like I said, we need to think about the community as well and how we can keep patients there, support patients there, remotely monitor patients there, and effectively get patients out of hospital safely, but in a timely manner. So I think, it's a race against the advances of medicine. It's fantastic that people are living longer, but it's not easy to build another hospital. It's definitely not easy to build a bigger A&E department. So we have to think about more innovative ways of being able to support the bathtub.
I think every one of these items that not just we're talking about and throughout the conference moves the needle a little bit. We all kind of have particular lanes we're in, and we all come together to hopefully make significant changes. Another big one I'm a fan of is decentralized care, whether we look at hospital at home or even emergency department at home. We talk about the lowest of low acuity and trying to funnel that off. But today we can send a paramedic with a pretty sophisticated lab in the back of a ambulance and go see and treat and evaluate a patient, do physician consultation, and that medic could spend 2 or 3 hours, give medication, see the response, and never ever go into a brick and mortar emergency department, and do that rather safely. It becomes a reimbursement issue that we should probably talk about at some point as one of the barriers.
Yeah.
I think another point we haven't touched on is that your question was, are we able to cope that in the future? And I think that gets back to the early years when we have to think about educating our children. Like you learn math, and now if you're lucky, you also learn lay resuscitation in school, yeah. But do you also learn about development of chronic disease? Do you learn that diabetes comes from nutrition? So I think it's all connected, and there's lots of technical solutions that should also be addressed in the early ages, where we actually have a chance like to create a different mindset. So your cortex knows when you're adult how behavior influences health, and it's really necessary to acknowledge that emergency medicine is a topic of public health at all. It's not about heroic resuscitation only.
Yeah.
I can add on just the global picture of what we're seeing here at Health. I think the technology, the groups of people that are involved in what we're developing or what everybody's developing here is key, I think, to like early identification of disease and trying to keep people healthier. It seems like a little bit of a roundabout way at public health that the technology needs to come in and help people like try to be healthy. It gives them their data, they can track on their phones, they can blow into a device. Whatever it is, they can identify some disease early, and from there, the hope is that they can get into a clinic and help manage some of these diseases and stay healthier longer. And then on the back end of it, just to what you were saying, Michael, to make sure people who do have perhaps that episode of care in the hospital, that they're on the back end of it, that they're safe. And we've seen some of the tools and individuals working on projects here. I think the startup winner had a nice wraparound care device or program where they're going to get nurses into the home super easily for patients who otherwise bounce back into the hospital. So I think the health conference has done a great job in bringing these people together, sharing ideas to kind of cope with some of these challenges that is going to come from this deluge of patients that are going to be arriving to the hospital more.
Jared, I'm glad you brought up the money issue because money matters. A lot of these solutions long-term will probably lead to less costs, but upfront they require an investment. And so when you talk to whether it's local governments, state governments, private parties, what is that reaction like? What do those conversations go like? And are the payers open to experimenting with these kind of new methods of providing emergency care?
Right, so great topic. So currently, at least in the US, the only way reimbursement happens to EMS is if a patient is put in the back of a licensed ambulance and taken to a hospital. So anything else, care on scene, et cetera, is not a reimbursable event. I'll say that the payers and the government systems, that sometimes the payer, they're often very intrigued when they hear that there are options when one of their members call 911 and doesn't end up in an ambulance, and doesn't end up in an ER. Because every time that happens, that's several thousands of dollars to somebody. So we disrupt that. So as of now, there's really not a good reimbursement stream for that, but it gives a lot of people question on, I can see this, but it becomes scalability, et cetera. But on a large population, I mean, before long, we're talking hundreds of millions or billions of dollars that can be saved, but we've got to be reimbursed to continue doing it. I mentioned like the emergency department in the home. I can send a paramedic to a home for 2 or 3 hours with sophisticated lab equipment, and if I could get reimbursed for that at significantly less than taking that patient to the ER and still do it safely, it would be a win. But we have to get that path and the payers on board to take care of it.
Hannah, what does the funding and those conversations look like in Germany? Because it seems like you guys have a lot of robust ideas that, or some of them are implemented and some that aren't, but what does the...
So our tele EMS system, that was kind of a best practice example for starting from a research idea, developing the technological solutions, the concepts, and then like 5 to 10 years later implementing it on a insurance refunded base. But that it took us 10, 15 years, and we had with the data to prove that not only the patient benefits, but we also spare resources, because in our city we did not have to implement new physician vehicles for that. So in the end, for the insurance, it was like paying something different, but not paying more. Yeah? So we got more out of it in the end. So I think for the when we develop new solutions in the early research phase, we have to think about the long-term implementation and the financing mechanisms. And we see a challenge right now with a system like a community paramedic, where different sectors are responsible for the financing. And now we have intersectoral financial discussions where we have to see, so who's going to actually pay? Yeah? And we haven't found the right solutions for that right now.
I was just going to say, obviously, because we have a publicly ran healthcare system, it creates a very interesting space when it comes to change and innovation, because it is all about how do we reduce down resources, whether that's time, a step in a process, money, of course, filling job vacancies and things like that, but without compromising safety, because of course it's not a paid value chain. It is about how do we save money for our NHS without compromising safety. So innovation's really interesting, because value for money, it has to be front and center of whatever we do. We have to be able to create value for our patients, for our workforce, for our organization, and it has to be cost effective. We have to be able to really demonstrate the cash releasing benefits of anything that we introduce into the system. So that creates quite an interesting dynamic, because you're effectively selling a solution to a company that has no money, because the NHS is in massive cash deficits. So therefore, what we're trying to do is save them money, but still deliver that same element of care. So of course it gets very expensive when someone lands in a hospital. So for us in the UK, there's a real focus on trying to prevent that as much as possible, but deliver the same level of care before they arrive in that A&E department. So it's quite an interesting time for us here in the UK.
Yeah, absolutely. I wish we had another 40 minutes, so we're going to do this rapid fire style, okay? If we had another hour to talk about other solutions that can solve the problem that we're talking about today, emergency department overcrowding and misutilization, what would that topic be that you would suggest, and we can just kind of go down the line?
I think it needs to be learning from more experience. It's been fantastic that we have a geographical diversity on the stage in terms of where we have learned from one another's challenges, but also opportunities. So I'd love to spend more time learning from other countries and be able to bring that into the UK, and we can learn so much from yourselves and all of the great examples that you've given today. So I think it's just about sharing that experience, and obviously a conference like this enables us to do that.
I think ultimately patients access the system looking for a solution to a problem, and what are those solutions? We can't keep doing what we're doing.
The data from the patient has to be available, all the steps it goes, so we can really learn from the data of the patient and all the chain of care where we can change or handle the system to have it easy access, understandable, fair, and equal for the patient.
It's so many different topics. I think a huge part of what we need to find a way to do is really focus on public health education and making sure that the health literacy rises and make sure people can access the care. We talked a little bit about Tequity. That's something that I think is going to be a big part of the next 15 to 20 years, making sure that people have access to all these incredible devices, tools, and knowledge. So that's something that we need to find a way to bring into the mindset of everybody, and use that as one of the social determinants of health.
Awesome. So we'll stay with you on the second rapid fire question, and I promise I won't hold you to this in like 5 years if it's totally wrong. But AI and telehealth is going to make a meaningful difference in this problem. Yes or no?
Absolutely.
Yeah.
Absolutely.
For sure it will, if we have the data available for the machine learning to process.
Absolutely, it already is, but we barely scratched the surface. In 5 years we won't talk about it because it'll be normal.
It will, but I think we need to start moving data more effectively, and that comes with democratization of data and the nothing about me without me movement, because at the moment our data is siloed in the hospitals where we live, rather than if we're on holiday, why can they not see our data? So yeah, I think we're moving in the right direction for sure. Okay.
And then if we're having this conversation 5 years from now, do you think we'll be in a better place, the same place, or a worse place?
I'm an optimist, so I'd like to say a better place. I think obviously there are lots that we need to do. There's lots of challenges. There's a lot of uncertainty across the globe at the moment. So I think I'd like to think, yeah.
I think because of things like HLTH and bringing everyone together, we absolutely will move the needle and be in a better place.
Totally agree, and would add that as we're facing a change of a law update on the EMS, I'm also very optimistic that will help to manage that.
I'm the ever optimist. The health conference has given me a lot of that over the past number of years. I think we're far ahead than I could have imagined from 5 years ago. So I'm excited for the next couple of years, the energy that this conference and the people here have brought.
Well, there's never been a time where I hang out with emergency medicine docs. That's not a good time, and today definitely held true to that. And I think for me, the takeaway was the geographic diversity, like you mentioned. We all have so much to learn from each other. I've learned so much from you all today. So thanks so much for giving us your amazing insights, and I can't wait to hang out with you guys again soon.
Thanks always.
Thank you.
Thank you.